Okay, I apologize. Once again, having technical difficulties. So, men and women are differently. So we see there 70% experience unusual fatigue, which I had mentioned already when the camera started to shut off on me. 70%. So is that an unusual symptom for women? No, it's not. However, unusual fatigue. You're used to being tired all the time. So this is, wow, I'm so tired, I just can't get off the couch type of fatigue. 40%, 42% are short of breath. So you are your normal day-to-day activities are now causing shortness of breath. Okay? I normally walk from my car across the parking lot to get into work, and boy, I'm really short of breath. I go up one flight of stairs, I'm short of breath. 35 to 39% experience indigestion and anxiety. Okay, during the heart attack, women are 58% short of breath, 56% unusual weakness, 43% fatigue, cold, 39% cold sweats and dizziness. Men tend to exhibit those typical classic signs of the chest pain and the left arm pain possibly progressing into the jaw. Those are typical signs. Pressure, an elephant is sitting on my chest, and shortness of breath. Kate Cook's husband was very short of breath, very fatigued, and had terrible arm pain. So those are classic signs for men. So sequela, okay? So the progression of coronary artery disease, okay? It's when we discuss, we will discuss angina in a little bit, and we will talk a little bit about this. But angina is that decrease in oxygenation, okay? So it's chest pain from lack of oxygen to your muscle. And we'll talk about that a little bit more here. And also some arrhythmias, okay, which could then progress into an MI. And then once you have an MI and you survive that, you can have heart failure because there's a section of your heart that was a part of your heart where the muscle has died or has suffered some sort of damage. But then, so what happens, that can progress to a sudden cardiac death because that section of your heart that is dead now has been damaged to the point where there's the impulses that can go through that heart to cause contraction is no longer there, so we can have sudden cardiac death or lethal arrhythmias. So those are definitely some sequelae of coronary artery disease that we try to avoid. Okay, again, all prevention of coronary artery disease, hypertension, all of those things can help prevent all of these things that we see here on the screen. So diagnostics, if they're suspicious of coronary artery disease and they want to diagnose it, excuse me, they will look at these things. I'm sure you have heard of the lipid profile, which is exactly that. That is where we're talking that lipid profile of your LDL, your triglycerides, your HDL, your total cholesterol. We'll look at all of those things. You do because they're lipids, which lipids equal fat, okay? Those are fats that are circulating through your body. Because they will have you fast 12 to 16 hours, typically 12. So usually if you're going to do this, you're going to want to take your test first thing in the morning, because go to bed, you want to stop eating the last thing you're going to have to eat. Maybe you've had dinner at 6 or 6:30. Don't have anything afterwards, maybe some water. But by 8 o'clock or so, stop what you're eating. You'll go to sleep. You'll sleep through most of your fasting time. You get up in the morning, it's around 8 o'clock. Maybe your test is at 8 o'clock. There's your 12 hours. So most of the time, this lipid profile is scheduled at the beginning of the day. Okay, just because it makes it, who wants to fast for that long all day and not take the test until 4:30? Not too many people. But keep that in mind. If that is the case, have they fasted? Okay, my sister-in-law, she's like, Carrie, my cholesterol was 400, my total cholesterol was 400 and something. I'm like, what? She goes, yeah, I had and it was 400. I'm like, that's freaking, what happened? Did you fast? Well, no. So you had a normal lunch. Well, yeah, I ate all day and then I went and had my blood drawn. Well, no, nobody told her you have to fast. I'm like, I can't even look at that number and you can't even worry about it until you fasted and they get accurate results. So very important as nurses, you have to fast. Okay, so an electrocardiogram, well, they will actually do an ultrasound of your heart and they're seeing how your heart is beating. They're seeing how your heart is perfusing the rest of it. It's looking at your left ventricular pressures. It's looking at how well you are producing your cardiac output. Okay, so they're looking at those types of things. Oftentimes they'll do an ECG, which, right? Well, I'm sorry, let me back up. TEE. I usually have to remember what the heck the long term is for it, but that is actually where they go in with a camera. They usually have to take something like a sedative. You're not knocked out, but maybe something, a drug to make you relax, like maybe some Versed. And what you will do is you will actually, the doctor will come in, sometimes it's at bedside or right at the office, and they will take a camera and they will go down your esophagus and will actually look at the top of your heart. That way it's a little camera, okay? Transesophageal, I think it may be echocardiogram or something like that. It's in your book. We're not going to go into too much detail about that. You don't need to necessarily know a whole lot about that other than it's a camera that goes down your esophagus to look at your heart, okay? You will see those at the bedside or in a physician's office, and they're really kind of neat to see. It's more of a diagnostic. They get a better picture than an echocardiogram. All right, ECG, we know what that is, right? 12-lead ECG. We're looking at multiple views of the heart to see if there's any tracings on our 12-lead show that there might be some damage to the heart or impending damage or ischemia. Okay, Holter and event monitors, those some of you may have already worn or have had. It can be 24 hours, it can be a month, where you're walking around with a Holter monitor and it's monitoring your rhythm for a certain period of time, 24 to 48 hours, or I've worn one for a month. All right, so stress testing also, you've heard about that. That's where you're going to get on a treadmill. Or if you can't tolerate the exercise of being on a treadmill to get your heart rate to a certain degree, which sometimes our elderly cannot, then they will inject in their vessels persantine, which will mimic the effects of exercise. It's a terrible feeling. You want to be on the treadmill rather than having this injected into you. It's a feeling, it's just a very unsettling feeling. It makes your heart go extremely fast, very fast. And it stresses your heart and it monitors your heart. You're on monitor and they're looking to see how your heart responds to that stress. They will also at the same time take a bunch of pictures, okay? We're not going to get into the next ones because I'm certainly not going to test you on that. And if you are working in a cardiac area, you will have to know these types of things, okay? But I'm not going to require you. It's a nice to know, not need to know information on those last two. All right, cardiac catheterization. Kind of what I have already talked about a little bit previously. We're not going to go into great detail because we will get more into this in 241 when we talk about it. However, this is something leading up to. If you're having chest pain that is coming and going, you're starting to feel short of breath, and they want to diagnose you to see how your coronary arteries, do you have blockages, they will perform a cardiac catheterization. It is the most definitive diagnostic tool that we have for looking at blockages. If we have small vessel disease, women, when I say we, it can be negative when they do this. Just to let you know, in the small vessel disease. However, in your large vessels, if you don't, they're diagnostic in there. Nursing implications. This, you obviously as a nurse are going to let your patients know what the procedure entails. Okay, you will be laying on a table. You will, they will place a catheter either into your groin and to your femoral artery, or it will go into your radial artery in your arm, and they will go on in there, and with a camera and dye, they will inject it in there, looking at your vessels. Okay. Some of the things that we want to remember is that your patient will need to lie flat for 2 to 6 hours, depending on where you work. Depending on where the procedure is. If it's typically in a femoral artery, which is kind of a big deal, or a femoral vein, if they go in that way, they will, depending on how they go in. Oh, sorry, I don't know what's happening here. All right, I apologize. But when they go in for your in your femoral artery or your radial, it's going to be longer because it's in your groin, and that's a much larger vessel in the artery in your leg than it is in your arm. You can imagine in your arm, maybe only 2 hours. You just can't bend your wrist. Okay, and it also depends on how they closed it. And we don't need to get into specifics unless you're going to work on a cardiac floor. But the way that they close the procedure, how they are preventing you from bleeding from that site. And then we have to keep in mind that what we're watching for. So for a patient, if you can think for a minute, as a nurse, they've just come back from cath and you are monitoring them. So what are the things that you're going to have to monitor? Obviously, in the groin or in the wrist, you're going to monitor for bleeding, right? Because they just put a catheter into your artery. And they need to make sure that clots and that there's no risk of you clotting or bleeding out. So you're going to be in there, and you're going to be really, it's a big deal for nurses post-cath to make sure, one, your patient is not moving around the bed where if there is a clot that is developing, that it can loosen, that they're lying flat. And when you're going to check, so maybe there's a large dressing, pressure dressing on it, and you're looking and you don't notice any bleeding at all. But the other thing you need to do is also assess for swelling, because maybe it's not bleeding out, but maybe it's bleeding to the inside surrounding tissue. That actually happened to a patient of mine. I didn't see any bleeding. I didn't see any swelling. The dressing looked great. The problem was I started to recognize that my patient was decreasing his urine output. I'm like, what is going on here? So I called at the time we have, we had fellows or residents that are taking call for the physician. So I call and, go ahead and give him some fluid bolus. Maybe he's just low on fluids. Okay, well, we do that. Nothing happens. He starts complaining of abdominal pain. Still, site looks great. There's no swelling there, but he's got abdominal pain, and now his urine output has decreased even more. He's not putting out anything. So his belly starts to look a little big. So we take him down for a CT. Lo and behold, he was bleeding. He had a retroperitoneal bleed, he was bleeding in and around its kidney. So that blood was forming around that kidney, causing his belly to fill, and what was happening was it was cutting off oxygen supply to that kidney, which equals low urine output. So, low urine output. Does low urine output equal bleeding into my belly? Not as a first sign. it's not the first thing that you think of. But because this patient was someone I was watching around the clock, I was in an ICU setting, I was watching him, I was doing checks on him all the time, I was recognizing signs, I was able to tell the physician, hey, something's going on there. 2 hours, he's not putting out urine. We've given him fluid, and now he's complaining of an abdominal pain, and his belly is tender to touch. We need to get him to a SAT CT, is what is ordered, and go down there. Sure enough, he's bleeding into his belly. Okay, so please use all of your nursing judgment. Do all of your assessment. Pay attention to your patient for something as simple, what could be as simple as a cardiac cath, could turn into, he could have died. He could have bled into his belly. I could have ignored it, and he could have died. So please, very important for you to monitor your patients around the clock and not forget about them. So depending on where that is, where the catheter is done, obviously if he was bleeding into his arm, we'd notice that a little bit faster than we would to his belly or to his leg. So also one of the things too is if he would have lost pulses in his feet, we could assume that something is happening there, something's occluding his arteries to his feet. We don't have pulses. We don't have strong pulses, so that could be also an indication. That's why that says it on the screen. So make sure you always establish a baseline for your normals. What does our belly look like now? How does it feel now? What does our groin look like now? What does our insertion site look like now? What are our pulses now? So that we know when there's a change, okay? So our management for coronary artery disease. We obviously want to make sure that we can decrease the serum cholesterol levels. We want them to stop smoking, right? Nothing that we don't know, all right? We want them to improve their diet. We want them to increase exercise. I know that doesn't always happen, but obviously from this lecture alone, we know why that's so darn important. Reduce stress. We all know that stress produces those catecholamines, right? Norepinephrine and epinephrine, which increases our heart rate, increases our blood pressure, etc., etc. So reduce stress. Management of other conditions. Make sure if you have hypertension, you're taking your medication like you're supposed to. Same with diabetes. You're taking your medication like you're supposed to. And a daily aspirin. We talked about that already. It prevents platelets from causing aggregation or accumulating, okay? It just is nice that it cannot, that we can take something so simple as an aspirin to help prevent platelet aggregation, okay? Please look at your Lilly book for aspirin, because this will be a common one that you will be asked of by your clinical instructors. Why is your patient taking aspirin? And I should not, nor should they, hear any of you say, for pain. One, they're in the hospital. They've got way better medications for pain. They're not going to give them aspirin. That's over the counter. So you know if they're taking 325, then they really want them to get a large dose. They may have had a history of clot formation, so they're going to take 325. But 9 times out of 10, you'll see 81 milligrams, okay? And that is a preventive measure, medication to prevent platelet aggregation, okay? So make sure you know that. Cholesterol reduction.